Hello there and happy Friday. I am going to get my friend Katherine on here. Step Up PT is the name of her business. We're going to get started talking today about complex dizziness. And let's see, I think, yep, here we go.
Hello.
Hi. Oh my gosh, I feel like we're getting so good at this. That was fast to get you on. Yay.
Yay. Well, thank you for having me, Julie. Always so fun to get to talk with you.
Me too. I actually, when I put on this shirt today, I was like, last time I saw Katherine, we were doing a dance and I had this shirt on. She also had a striped shirt on, and I was just like, oh, I was excited to see
you. Yeah. Yes, and I do the shirts I'm wearing depending on which patients I'm seeing, like how dizzy provoking is this pattern?
Right. Stripes are very bold,
and...
right? And can be dizzy provoking. So yeah, these are the things that neurotherapists think about.
Sure. We do, yes. And I love that we're getting to talk about one of my passions today, Otolith, and especially the crossover with autonomic function. It's like my favorite.
Me too. So I feel like we should just dive right in to this. I am curious first, like, how did you come across this connection?
So that's a great story. So we kind of inherently know, right, that there's some connection between the vestibular system and autonomic, because so many of our patients, when they're really dizzy or experiencing intense vertigo, have autonomic symptoms like increased heart rate, respiration rate, they get sweaty or feel flushed, have the nausea and possibly vomiting. So we knew that there's some vague connection there, but it really wasn't until Jaimy and I were doing a deep dive into the literature for positive spin on dizziness 1 that I came across some really amazing stuff. So I was trying to find articles on vestibulospinal reflex, and I just stumbled across vestibulosympathetic response. And at first I thought, oh, that's weird, that's a typo. They've wrong VSR. And then I'm like, well, all these articles can't be typos. And so then I read the Yates article, which you'd shared on Instagram the other day. And that was like mind blowing. I'd been doing vestibular stuff for 20 years and had no idea that there was such a thing as a vestibulosympathetic response or reflex. It was amazing and gave me a whole new appreciation for the otoliths, because it's the otoliths in particular that are part of this reflex and not the canals, which they know through some really well-crafted studies. And so basically, it turns out the otoliths help with our blood flow distribution and help to support our blood pressure. And it's amazing feed-forward system, so that when we have a big change in position where our otoliths are sensing this linear translation, like going from supine to standing or sit to stand, then the body sort of anticipates this drop in blood pressure, right? So through this vestibulosympathetic response, we actually get increase in vasoconstriction, heart rate goes up, and we help to thwart any orthostatic hypotension. And this all happens on like milliseconds, like 50 to 100 milliseconds, which is so amazing that the otoliths are part of this. In comparison to our baroreceptors, which require a drop in the blood pressure to happen first. So they're more of a feedback system. And they are involved in both sympathetic and parasympathetic, different from the otoliths that are really just for this particular response, just a sympathetic connection there. But the baroreceptors are like 1 to 2 seconds. So we have to start feeling that blood pressure drop before they kick in. So otoliths are amazing that they're part of this supporting the blood pressure. And it really helps to explain then when we start to see some more otolith dysfunction and then some orthostatic intolerance or orthostatic hypotension, that maybe it's not just your run-of-the-mill orthostatic hypotension, or we're seeing this in more complex dysautonomia, that maybe we need to go back and look at otolith function and break out that cheat sheet and do some of the other tests to see, well, maybe their dizziness from changing positions isn't just the blood pressure, but also the otolith dysfunction compounding that change in blood pressure. So
like mind
so
blown. Jaimy commented on here that maybe you didn't sleep that night that you discovered this. And you're right. When I went back to look at that article again, which I got from you all, I found there was a lot of stuff on vestibulosympathetic. And, you know, we talk about this a lot. You talk about this a lot, like with dysautonomia. And it's like, why aren't we talking about the otolith more here? Why is that missing? Which is why we're obsessed with it, right? Like,
absolutely. And it's so much in the cardiac literature and not in vestibular. It was just like all these cardiologists knew it existed. Like nobody in the vestibular world, or at least I certainly didn't. And it wasn't anything I'd ever been taught in advanced courses, or definitely not in PT school, but just so incredible that the otolith would have a role in supporting blood pressure here. And it also is just involved in sympathetic tone in general, because it relates to the vestibular nuclei, which then go down to the rostral ventrolateral medulla, which has a big part in regulating blood pressure. So it's more involved in our autonomic nervous system than I had ever appreciated beforehand. And we can see this go awry. So if we have like a sudden change in otolithic input from maybe having a vestibular migraine attack somewhere centrally, it's not getting processed properly, or a person has a Meniere's attack, that we can see then this otolith input change, and that can then, because of the vestibulosympathetic response, we actually become momentarily hypertensive. And then in response to that elevation in blood pressure, the baroreceptors kick in, and then we have a massive drop in blood pressure, and that can cause like a syncopal episode. So interesting it made me appreciate diving more into when a patient says they just suddenly fell. And I, in the past, thought, well, they probably tripped or slipped and they didn't really recognize that happened. Or certainly, you know, if they all of a sudden had this massive like vertigo attack, that sure, you could become disoriented and fall. But even in the absence of like true vertigo, a person can have this, it's called this otolithic crisis, or Tumarkin's crisis, also vestibular drop attack, because we love to name everything multiple times over. This change in otolithic input causes this whole cascade of events that can result in this episode where we're just on the ground and have no idea how we got there. And it's just seconds long, so we rarely capture it in clinic or even on camera. But helpful to then again tease out, like, how did that fall happen? What do you recall occurring? So that again, maybe triggers us to go back and look through that otolith exam a bit more and see, is there more of an otolithic component than we are appreciating?
It makes me think of so many things, because I met a gentleman who had an acute concussion this week, and one of his main symptoms was feeling like he was being pulled over to the side, like a magnet, like he was swaying, that he was still on a boat. And he had he had several blows to the head, right? And several blows to the side of the head. And of course, nerding out on the otolith this week, I was reading the concussion literature and how sensitive the otolith is post-concussion. And we know the autonomic nervous system is sensitive post-concussion. So you could really have a double whammy there, right?
Absolutely, for sure. You have the labyrinthine concussion on top of your other central symptoms with the concussion. And then if it is impacting particularly the otolith, where now you're having some more autonomic changes on top of the autonomic changes you might already have from the concussion. Yeah, and it really highlights again, like, the importance of seeing a concussion specialist and getting assessed properly and starting that early exercise. I think that I don't know that the literature is cut up to this idea, but Jaimy and I were kind of hypothesizing that early exercise helps to regulate that autonomic nervous system. You're not getting that orthostatic hypotension and intolerance that can happen post-concussion, probably because you're getting otolith stimulation that we were in those days of like the cocooning and rest until you feel better, the poor otoliths were getting no stimulation. And so that whole chain of events would just get really wonky from not having proper otolith input. Yeah. And it is interesting. It does cross over so many different diagnoses.
That's why I think about this a lot. You know, I certainly think of you and Jaimy as like my dizziness duo, the people I go to. And yes, it's dizziness, but I actually think what I've learned from you all with the otolith and these complex interactions goes far beyond dizziness. It goes to function. It goes to how our brain is weighting sensory information from all the different systems. It goes to what we do with kiddos that are autistic or have sensory processing differences, and just so many things that I really wasn't aware of, to be honest, until talking to you all.
Yeah. Well, and it was having to prepare for the course and like diving into literature that we accidentally stumbled across. And Jamie's right, we did not. We were like, oh my gosh, just texting each other like, did you read this line? That was like, it really, like, that many decades in, do you just feel like, how have I never known this information? Like, that was such a game changer for us. And also then starting to learn more about the otolith connections too with the hypothalamus pituitary adrenal axis, with our whole stress response and how those interact with our autonomic responses as well. And thinking about the otolith, actually the canal too, I can't leave them out, but they relate to the solitary nucleus, which is a major hub for information from our vagus nerve, right? So now we see this parasympathetic interaction, and it's why things like bouncing or rocking can be really soothing, is that we're stimulating that parasympathetic nervous system through some otolithic input. And you think about, like, with babies, how we so often just instinctually start doing a little bounce or a rock, and it's just like built in that, okay, those are things that help to calm us. And again, things to play with patients. Do those motions help to settle things down by restoring kind of normal input and then tapping into that autonomic nervous system? And that they're not for everybody. Some people will feel more stirred up, but certainly just things to like think about that we can capitalize on and have at our disposal. You don't need any fancy equipment for things like, let's maybe bounce on the ball, and if you don't have a ball on your bed, and we can all do things like rock in place or shift front to back, and those translational motions are all otolith.
It's really fun. I love me a good rocking chair for sure. It was after this course, I think, that we ended up with rocking chairs in our clinic, and now it's the most sought after chair. This leads, like, you're sharing so many great tidbits. It leads me to think about what we just announced today, is that you and Jaimy are doing a brand new free webinar for people. And I got so excited today because I've heard from people who have used, we have a free cheat sheet for evaluation of the otolith, who've used that and had immediate improvement in patients. And I know that because I've had that too. Yes. But we've had 900 people download that freebie. So I'm like, 900 people are getting this. And really the next step is this webinar, and it's called an otolith mixtape. I know I made mixtapes many in high school. Not as common now, though we do still have a tape deck at our house. But this mixtape is really bringing some of those concepts that you've been talking about that have been evolving over the course of putting together these positive spin courses, the otolith, the assessment, treatment, and connecting that to diagnoses too, particularly vestibular migraine, which is near and dear to all of our hearts. So I wonder if you could talk a little bit, because we just announced it today that we're doing this free webinar. It's on July 7th, so it's coming up here quickly. Talk about those pieces and how they're connected between the otolith assessment and treatment and vestibular migraine.
So we went into this in depth in Positive Spin 2, the whole vestibular migraine. And so kind of the crossover in this webinar are some of the assessments and how people with vestibular migraine tend to have certain positions that are less well tolerated. So we see people with vestibular migraine having trouble with motions in the roll plane. So doing this, and the faster we go, it's more canal bias. But if we hold and stay there in the static tilt out of alignment with gravity, we're biasing the otolith. And people with vestibular migraine tend to have some difficulty holding those positions and feeling oriented. I believe there's a video of me during vestibular migraine that, if it's not released yet, is going to be in some of the emails. And you see that I do have, I'm pretty okay with my eyes open upright. In fact, I didn't even feel all that bizarre. I knew that I'd had a regular migraine attack that day. And then Jaimy and I were just filming to do our tea time with Jaimy and Katherine. And we were like, hey, let's just see how I look. And I just start drifting off to the side. I didn't even really know that that was going to happen. And then we just kept playing with, well, now let's look at with a head tilt. How does that change things? And so that was definitely this crossover with vestibular migraine and biasing the otolith. So that's a lot of what the webinar is. How do we take pieces of the otolith exam and really tailor it to people with vestibular migraine? What do we expect to see? And then how do we go about turning those tests
which
into
is like
treatment?
the brilliance of all of this. I think anytime you can just simplify, well, we just tested that, so we're gonna treat it, is so great. And so, yeah, Katherine sent these videos and I was watching them just yesterday, I think, and putting together some videos for everybody else. And you're almost falling over at one point when you close your eyes and you're tilting, right? And there's a strong preponderance to one side. And this is outside of an acute attack. And I think that's one of the other things, is that we used to kind of understand migraine as just like this attack. And there's just so much more, for sure. Wish I had known this 20 years ago. When I was seeing a lot of folks with vestibular disorders, I think I missed a lot of this.
I for sure did. And I didn't even really know how common vestibular migraine is, that it's like the most common diagnoses in a vestibular, an ENT's clinic or neuro-otologist clinic. And the second most common cause of episodic vertigo after BPPV. So we are seeing it a lot more, and it tends to be underdiagnosed because people don't necessarily have a headache component to the vestibular migraine attack, so they don't connect the two. And migraine itself is underdiagnosed. So some people who've been going around for years thinking they have chronic sinus infections are actually experiencing a migraine. And so then they're never really well diagnosed. So of course, in the vestibular migraine diagnosis doesn't come about, and it just gets missed a lot. But yeah, so to know more about what to expect with vestibular migraine and some of the sensitivities a person has can really change then how we go about treating, and understanding that approach to vestibular migraine rehab is not the same as just about anything else. It's totally different, slow and low approach. Because of, and that's, so we go into in quite a bit of detail in Positive Spin 2 about all the different mechanisms that contribute to vestibular migraine, and so much of it being just the central processing and this hypersensitivity. So you can't give a person with vestibular migraine times one viewing, do it for a minute. They are not coming back.
And they're so sick. Yes. And so one of the things I was going to say for this webinar, I think it's so nice to put those pieces together. I think it's going to be very actionable for people. I also know that you and Jaimy put together a little treatment helper handout for people when they come live. So if you can come live on July 7th, yes, save the time. It's 5 o'clock PST, July 7th. We will have the recording available as well, but a special little gift if you can come live. Somebody asked a question. I think this is a good question. You kind of alluded to it, Katherine. rocking chairs or swings, what could be a play for people who feel dizzy in those? Because we were talking about how that stimulation can be helpful for things, but we definitely know it is not for other things.
It's not for everybody, no. And it can, then we're teasing out, like with rocking chair, because you're getting forward translation, but there's also a little bit of canal to it too. So it's helpful to tease out, is it more of a canal hypersensitivity? Is it more of the otolith hypersensitivity? And then can we take those two apart and address them separately so that it's not so sensory overwhelming for a person? And sometimes it's just that forward translation. So those can be people in like traffic when there's lurching that just start to feel nauseous, have those autonomic responses with it. Well, then that's more otolith, right? So we can start to kind of tease the two apart, and then try to find a graded manner to allow them to do those motions, so that it's habituation, but habituation different from our typical canal. No. Yes. Right. We can apply the same principles, but with different strategies so that we can allow for that forward, fore-aft translation to not be so stimulating in a negative way. Yeah, that's a great question.
That's great. And one of the things I think that I'm hearing from therapists with the cheat sheets and even from the courses that you have done over the past couple of years is how this is different than this, and this wasn't working for people, which is like absolutely what we have seen too, right? If it's not a canal, if it's not a VOR issue, this is not our approach. But that's in a like basic entry level, that's all you learn, right? And
right. And for a lot of things it is appropriate, but then there are definitely situations like somebody's commented elevators are a nightmare. That is 100% otolith, right? And that's all this like saccule motion, and it's passive, so we can't anticipate when it's coming. Elevators, especially with there's no like visual reference because the doors are shut and we can't tell how we're moving. Yeah, elevators can be really tricky. And then your traditional rehab approach is not going to address that saccule hypersensitivity or saccule dysfunction there. So absolutely, we have to think in a different way, addressing those components that a person has. And the times-one viewing or some other more traditional approaches might improve a person so far, and then we kind of hit a wall because we're not looking at this whole other huge component to our vestibular system that has just kind of gotten the shaft
right,
for no good reason.
Right. And I talked about this with Jaimy too earlier this week, that idea of having an off switch. I'm thinking about this person that's saying elevators are a nightmare, and particularly if you don't have any way to turn down or lower the dial on those symptoms. And that's like one of the first things that you have taught us is like address that piece first.
Yeah. Absolutely. Yeah. And sometimes that's all we do with a person on that first visit is it's just so much education, and then figuring out how do we make you feel better, right? We know that, yes, we have to make a person a little bit dizzy, and through that habituation, get them better. But we can so much more readily help a person if they know they have a method to bring that dizziness back down. Or if they're already starting at a 7 out of 10, it's hard to say, you know what, I'm going to do these exercises that make me feel absolutely awful. Let's bring you down first, and then you can tolerate doing exercises up to like a 5. But yes, there's so many strategies we use that Jaimy had gone over with you on
Tuesday.
Wednesday?
I lost
What day was
track
that?
of the week.
Tuesday. But teasing out, like using somatosensory, capitalizing on more input there, using more graviceptive cues. How do we use weights to our benefit? What are things we can do? You're in an elevator, you're probably not lugging around 3-pound weights in your hands. So what are some other strategies that we can use there? But knowing those things can be such a game changer in a person's rehab course, that I've got a way that and control it on my own when we often feel super out of control with dizziness and vertigo. I have a method that works for me to just calm things down. It's huge to have that.
It is huge. And that's the piece that I see can give immediate results, right? And I think as therapists, you know, when we treat BPPV, we love that there is like an immediacy to the treatment. Like, boom, we just move those crystals and you're better. And there are pieces of this that, like, in my view, in the past, I was like, complex dizziness, this is going to take me a few sessions to figure out. And I actually think with the approach that you teach, immediately, like very first session, we might not figure out the whole thing, but we've got some tools and we built some tools for that person right away, and they feel a whole lot better. And then we can really start to progress that habituation piece. And that is my like point of like, you got to come to this webinar, because I think every therapist should have those tools. And I think if this person sharing elevators are a nightmare, I want you to have a therapist that will use some of these tools to explore. I guarantee, because elevators are a nightmare for a lot of people that I have seen, but I have seen them universally get better. I've never met a person where it didn't get better. And so I have a lot of hope for you, but I also have a lot of hope for therapists of having some more tools beyond traditional vestibular therapy to help folks like this.
Absolutely.
So,
no, I think yes, the more tools, the better. Right.
Exactly. Especially as the layers of complexity add up. It's nice for us to have tools and to build tools for our patients. So what I was going to remind folks is that this live webinar, Jaimy and Katherine are teaching. It's called the Otolith mixtape. And so you can treat complex dizziness like a pro, like Jaimy and Katherine. And it is live on July 7th. It's a Friday. So, you know, just finish off your work week, join us with your kombucha, or I've been really loving these little poppy drinks lately, but join us for your evening of learning and hearing straight from Jaimy and Katherine a lot about this. I actually know we have already over 100 people signed up for that webinar. So come join the party. I think it's going to be great. Every time, honestly, I sit down with Jaimy and Katherine, even for things that I have like heard before, it like sinks a different, or I learn something a little differently and can apply it right away. Honestly, after talking to Jaimy this week, and then I met that gentleman with a concussion, I felt like I had so much more to share with him. I was like, let me tell you about this. Like, I'm so excited. I had to tell him about the Otolith. And he was like, you know what? That makes so much sense. It makes a lot of sense. And I was like, yeah, it does. It's the Otolith. So thank you for helping me as a therapist, but helping so many people as therapists.
Oh, we love it. We love it. We love getting to share what has worked for us and the little tools we've picked up over the years and tried out, and absolutely want people with dizziness to feel better when we know that they can. It's just looking at things in a slightly different way, having a few more ways to assess a part of the vestibular system we tend to overlook, and really turning those things into treatment, and so effective for folks that we just feel like, I don't know what to do with you anymore. There's a lot that we can still gain and help a person with.
Absolutely. Well, you all, if you're a therapist, go sign up. It's at reactiveeducation.com. And if you're a patient, go send it to your therapist too. We would love to have lots of folks in our webinar coming up in a couple weeks. And Katherine, it's so good to see you.
Yes. You too, Julie. Always a highlight of my day when we get to chat.
Me too. So thanks so much. Have a great weekend, and we'll see you soon.
Thanks.
Bye.